And it's a pleasure to invite our keynote speaker now, Dr. Sanjay Asrani, who will not only educate us about diurnal control of intraocular pressure, but also give you a break from angle closure.
No, this is not a relief from angle closure attack. This is just a different topic that we are going to be talking about, just that may be related to angle closure, but it could be that it can apply to all forms of glaucoma. So may I have my slides? It's up here, but I'm not able to see it there. Okay. Yeah. There we go. Thank you. So we are wanting to see the complete picture of the jigsaw puzzle, which is glaucoma. And I would like to share my insights about the diurnal IOP variations that happen in glaucoma, and how am I using the currently available instruments in which kinds of patients, and how is that result actually making a difference or not to my management. So intraocular pressure that we measure in our glaucoma patients is about 3 to 4 times a year, a total of about 6 out of so many million seconds in a year. And very little is known about the pressure fluctuation because we don't have a method to measure the pressure in the patient's own environment. Imagine measuring diabetes just 3 times a year by going to a pathologist, in contrast to somebody doing home glucose monitoring. So there have been many attempts to do home tonometry. The first one was this device on the left, which was an applanation device. Of course, did not get permission from the FDA because for its commercial use, because it needed an anesthetic. Then some people decided to go and buy their own air puff tonometer and tried to measure their own pressures. Of course, you squeeze a lot when you try to anticipate the puff of air coming to you. And the third is when we tried to use the TonoVet and the eye care rebound tonometry from the animal machine to the humans, and then when the human devices were available, we started using it by the patients themselves. Now, what is the data that you see? IOP fluctuation has been probably maligned quite a bit because people say, look, I'm rubbing my eye and my pressure goes up to 70 millimeters of mercury and nothing happens. So how can fluctuation be important? But it is the ultra short type of fluctuations that actually are not important. The one that you rub your eye, you hold your breath, those that happen in minutes are not clinically relevant. But short-term fluctuations, like those that occur over hours and days, and longer-term, what we can measure in the clinic, definitely make a big difference to the glaucoma management. And this is a paper, again, published late last year in PRER on the importance of IOP fluctuations. And it is freely available on the internet for anybody to see. It's a comprehensive review on all of IOP and its fluctuations. What we have a dearth of understanding is the baseline characteristics of a normal human being, not an eye with glaucoma, not somebody with glaucoma. What does their pressure fluctuate at? So patients with no glaucoma, less than 3 millimeters of mercury is majority of the eyes. 3 to 5, a fewer. And more than 5 millimeters of mercury, extremely few. So this is for normal eyes, that most of them fluctuate less than 3 millimeters of mercury. We had done a study long back and published in the year 2000 in Journal of Glaucoma, where we found that the patients who had greater fluctuations of pressures as measured at home were actually progressing much faster than those that had a tighter control of their pressures over 5 days. And the difference was almost 6 times that the eyes which had a range of about 5 millimeters of mercury were progressing 6 times faster than eyes that had only 3 millimeters of mercury. This was published 25 years ago. And this was done with that applanation device of almost 700 eyes. And this was a study that showed that pressure fluctuations actually do make a difference. Then subsequently some multi-centered trials also reanalyzed their data and found that in the AGIS or the Advanced Glaucoma Intervention Study, longer-term IOP fluctuation was related to progression, especially if you have brought the pressure down below 20 millimeters of mercury. Once the pressure gets controlled, pressure fluctuation becomes vital. And so you can see here, if the standard deviation was greater than 3 millimeters of mercury, all of those eyes progressed. So the target range for glaucoma, which I set and I use in my clinic, for advanced glaucoma, I set them into the low teens, and I like a least fluctuation tolerance of less than 3, moderate mid-teens less than 4, and mild high teens less than 5. What about accuracy? Nearly 30% of all Goldmann tonometers at an academic medical center had a calibration error of more than plus or minus 2 millimeters of mercury. And 1/5 of them remained with that error even after rechecking after 4 months of calibration. So how are we really going to measure fluctuation when our instruments themselves have so much error rate? On top of that, the Goldmann machine, which is considered gold standard, is unfortunately reader dependent. The reader has to decide where those two Myers are meeting. If the Myers are thicker, you can underread the pressure, and vice versa. So it is individual dependent. And if there is a bias in the mind, they can underread or overread easily by 2 millimeters of mercury. If you're trying to detect fluctuation more than 3 millimeters of mercury, that may not be the best instrument, because you will never know whether the technician made an error, whether the machine made an error. So that same study that was published in 2023, looking at the baseline characteristics of a randomized trial of healthy adults, they found that the Goldmann tonometer had a correlation R square of 0.68, in contrast to the iCare rebound tonometer, which had a much greater reproducibility. This tonometer is the only tonometer that we can use which doesn't require an anesthetic apart from the air puff tonometer. This tonometer, thankfully, is agnostic to which individual is using it, because it gives you an average of 6 readings. Secondly, the patient is not straining into the slit lamp when somebody is measuring this thing. This tonometer has some downsides. It should not be used in patients whose corneal thicknesses are greater than 600 microns. Any thicker cornea will cause this rebound tonometer to measure excessively high, and you'll get unnecessarily concerned. So we use it for eyes that have normal pachymetry or lower pachymetry, because it doesn't matter which technician is going to use it. Secondly, I've had this tonometer now for over 20 years, and I have not needed to calibrate it. That is what I need to be able to detect fluctuation. I must tell you, unfortunately or fortunately, there is no other company yet that is making this kind of a tonometer except Reichert in the US. So this company, iCare Finland, is the one that makes this tonometer, and this is the one that I use, and they give me research instruments to use for my studies. So this is the iCare Home 2, which we are using, and this one is showing very strong correlation to if patients use it, if trained operators use it, and sometimes even compared to the clinic instruments. So let me share some clinical vignettes. This is a patient, 66-year-old patient whose clinic IOP is always 10 to 12 millimeters of mercury. But this patient's visual field, the top one is the more recent one, is getting worse, as you can see. And unfortunately, this is the worst place to have visual field defects, right close to the center of fixation. He's 66. If he's losing his ability to read and to look down, to walk downstairs, and he's getting worse, and his pressure is only 10 to 12. Every time he comes in is 10 to 12 in the clinic. So I recommend a trabeculectomy to him. But he says, no, 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 you prove it to me that I need it. So we did a home tonometer, and as you can see, the one measured in June, which is in the blue, you can see the fluctuations that is happening. Again, note, the pressures are all within normal range, barely reaching about 12. But look at how the fluctuations are happening. And now, after trabeculectomy, you can see how the pressure fluctuations has decreased significantly. But he was not convinced because he was normal tension glaucoma patient. You know, they never get convinced, right? They're always skeptical. He said, but maybe because I stopped drinking coffee. That's why my pressure fluctuation went down. How do you know that it is the surgery? So we said, okay, let's do the other eye. And so we did the other eye. And the other eye pressure fluctuation has stayed the same from June till January. Only then did he get convinced to undergo trabeculectomy in the other eye too. And he wanted to see the difference, you know, in the right eye after trab and the left eye before trab. This is the left eye before trab and this is the right eye after trab. This is a 42-year-old male with headaches, narrow angles, convinced that the headaches are coming from raised pressure. This patient insisted that he has narrow angle glaucoma that is happening. And I said, okay, we'll do a laser iridotomy, and your headaches will not go because your headaches are not coming from narrow angles. They're coming from dry eye. But he wasn't convinced. We saw the OCT was not changing over time. He bought himself a home tonometer just to prove me wrong and showed me that indeed his pressures are reaching 26 and 32. Look at all these spikes. He said, see, doc, I told you, I'm getting pressure spikes. That's why I'm getting these headaches. You need to treat me for high eye pressure. Is anybody able to notice what's wrong in this? The next slide will show you. Look at what time all these spikes are occurring. Between 4 a.m. and 8 a.m. There is no spike after 8 a.m. He is doing the waking IOP spike measurement. He would get up in the middle of the night, immediately reach for the tonometer and measure the pressure. Everybody's pressure goes up as soon as you wake up. It comes down after 15 minutes. So if he's going to measure, this is all false. This is not real, true rise in pressure. So I had to tell him, stop measuring after 15, 20 minutes and don't wake up in the middle of the night. So he's still stable after many years. This is a 50-year-old Indian female who underwent SLT in both eyes, but is continuing to progress. As you can see, there is progression in the inferior part of the macular thickness right here. And if you look at the pressures look the same in the left eye and the right eye in the clinic. We did a home tonometry, and we found that the pressures are indeed spiking to 25 despite SLT. And therefore, we were able to treat this patient because we found that the standard deviation was 2.7. This is another patient, sorry. This one is a monocular patient, 59-year-old. He has lost his other eye to high myopia, detachment. Okay, last two slides, thank you. But we needed to convince ourselves that he is getting worse because of pressure fluctuations. And indeed, this was able to convince us. And this is another patient that shows you the exact opposite. Patient's visual field got worse. Pressures in the clinic, stable, normal. Patient has diabetes, hypertension, so there is very low risk of low pressure glaucoma. We did home tonometry, Standard deviation is only 1.3. We decided, no, this patient is not going to get a glaucoma surgery despite visual field worsening. Patient goes to see a retina specialist. The retina specialist says, my view inside is not so good. Maybe you should consider a YAG capsulotomy. We do a YAG capsulotomy, and sure enough, this visual field worsening goes away. So this actually saved us from having done unnecessary glaucoma surgery. Thank you very much for your kind attention.
Thank you, Dr. Sanjay. Amazing talk, a lot for us to learn, especially related to eye care. Probably we'll get it soon.